So now we will discuss the imaging findings in trauma cases. So the left is the axial non-enhanced CT scan of a prisoner, which was imaged for head trauma, and it shows no gross abnormality. The right is the scout view in the same patient, and it shows a foreign object, that is the handcuff key in the prisoner's mouth. So he faked the injury and was planning to escape, but the radiologist alerted the guards and thwarted the plan. This case illustrates the importance of looking at the scout view in every patient, especially those which are being imaged for trauma. Left is the axial non-enhanced CT scan in a 64-year-old female with a ground level fall, and it shows only a small linear hyperdensity adjacent to the fox cerebri and torcular herophyly. The scan was initially considered normal. Right is the coronal non-enhanced CT scan in the same patient. It was reformatted from the axial source data. Note thin peritentorial acute subdural hematoma, which is nicely contrasted with the nearly invisible normal left side of the tentorium. Left is the non-enhanced CT scan in a 3-year-old boy with severe head trauma, and it shows the brain swelling with obliteration of all the sulci and subarachnoid cisterns, the intracranial air, that is pneumocephalus, and subarachnoid hemorrhage. Right is the bone CT scan in the same patient, and it shows the importance of determining that why the intracranial air is present. Multiple skull fractures are noted here, including a longitudinal fracture through the arated right temporal bone. So these are the introductory images to the CNS imaging of trauma cases. So left is the coronal graphic, and it shows 3 lines which are defining the 3 classic types of Lee-Ford fractures. Now, the green line is representing the Lee-Ford 1 fracture, and it is seen to be involving the maxilla and the nasal aperture. The red line is the Lee-Ford 2 fracture, which is also called pyramidal fracture, and it's extending upward across the maxilla and across the inferior orbital rim and nose. The black line is basically the Lee-Ford 3 fracture, which is also known as craniofacial separation, basically, and it extends through the orbits and zygomatic arches. The right image is the 3D CT scan, and it shows a Lee-Ford 1 fracture through the maxillary alveolus and nose. So left is the sagittal reformatted bone CT scan, and it shows a Lee-Ford 1 fracture, which is extending from the maxillary alveolus into the posterior sinus wall and pterygoid plate. Right is the 3D CT scan, and it shows a Lee-Ford 2 fracture through the nasofrontal junction that descends obliquely through the inferior orbital rim. A Lee-Ford 1 fracture is also present through the maxillary alveolus and nose. A non-displaced mandibular fracture is also present, and it is common to have multiple types of facial fractures in the same patient. Left is the 3D CT scan, and it shows a Lee-Ford 3 fracture with frontonasal diastasis, orbital wall fracture, and diastasis of the zygomatico-frontal suture. Right is the axial bone CT scan in a complex midface smash injury, and it shows the comminuted depressed nasal bone and ethmoid fractures, maxillary sinus fractures, and zygoma fractures. So left is the bone CT scan with sagittal reformatting, and it shows the antero-posterior alignment of the cervical spine, which appears normal. However, there is increased distance between the occipital condyle and the C1 lateral mass, as well as widening of the C1-C2 articulation. Right is the sagittal stir sequence in the same patient, and it shows how MRI better depicts the soft tissue injuries. Widened occipital condyle, C1 and C2 articulations with hyperintensity in both joints are noted, and the posterior ligamentous C2, C4 injuries are also present. Left is the lateral radiograph of the upper cervical spine, and it shows the malalignment with the spinal laminar line of C1 in front of C2 and C3. Lucencies through the posterior C1 ring are fractures. Right is the coronal reformatted bone CT, and it shows the coronal displacement of both the C1 lateral masses. Also seen is a bony fragment due to the transverse ligament tubercle avulsion. Left is the sagittal graphics sequence, and it shows an unstable cervical hyperflexion injury with disruption of the anterior and posterior longitudinal ligaments, as well as the interspinous ligament. Traumatic disc herniation is also seen. Epidural hemorrhage and cord injury is also noted. Right is the sagittal reformatted bone CT of a cervical spine fracture in a patient with ankylosing spondylitis, and it nicely shows the bone injuries but does not depict the extent of soft tissue damage. So MRI is basically complementary to the multiplanar CT. So some more images of scalp and skull injuries. Left is the graphic, and it shows the skull of a newborn, including the anterior fontanel, uh, coronal, metopic, and sagittal sutures. Cephal hematoma is subperiosteal, focal, and limited by sutures. Subgaleal hematoma is under the scalp aponeurosis, much more extensive and not bounded by the sutures. Right is the bone CT scan in a newborn with a traumatic delivery, and it shows a linear skull fracture and cephal hematoma overlying the parietal bone. Also noted is the cephal hematoma. It does not process. It is not crossing the sagittal suture. So left is the image is the bone CT scan, and it is showing a diastatic fracture of the sagittal suture. A very large subgaleal hematoma is noted to be extending around the entire circumference of the skull. The superior sagittal sinus is torn, and the intracranial blood seen on soft tissue windows was a vertex venous epidural hematoma. Right image is the T2-weighted MRI scan in an abused infant, and it shows a very large mixed acute, subacute, subgaleal hematoma, which is seen to be crossing the sutures and extending over the face and orbits. Some more images of scalp and skull injuries. Left is the bone CT scan, and it shows scalp laceration and soft tissue swelling overlying the bilateral linear skull fractures. The right lambdoid suture is diastatic. Right is a 3D shaded surface display in the same patient, and it shows the right calvarial linear skull fracture. Another linear fracture is present that is seen to be extending into the right lambdoid suture, causing a diastatic fracture. The lambdoid suture cephalic to the fracture appears normal. It appears more normal. Left is the axial non-enhanced CT scan in a patient with head trauma while bicycling on a gravel road without a helmet, and it is showing a lacerated avulsed scalp, extensive subcutaneous air, and multiple hyperdense foreign bodies. That is, it's a road rash. This is called road rash. Right is the axial non-enhanced CT scan with bone algorithm reconstruction. Wide window display shows a depressed comminuted skull fracture involving the right squamous temporal bone. Also noted is that the subcutaneous air and soft tissue hematoma, which is seen to be overlying the fracture. Left is the axial non-enhanced CT scan in a patient with a growing skull fracture, and it shows widened fracture with scalloped margins. Right is the axial T2-weighted MRI in the same patient, and it shows a lobulated CSF collection, which is filling the growing fracture. CSF pulsations have widened and scalloped the calvaria.